Hello, good afternoon. Welcome you all. I hope that you've been able to log in smoothly. I have the privilege and the joy of sharing talk among medicine professionals with different specialties related to sports medicine. I would like this to be an introduction to a new master's degree of medicine and sports science at the European University of Madrid. So before speaking a little bit about the curriculum, I would like to introduce you to Dr. Manuel Leyes, who is very well known by everybody that belongs to traumatology, sports traumatology world. Currently, he works for Olympia Center as manager of orthopedics and surgery services, but previously he has a very vast experience with the world of professional sport in the US, with professional NFL sport teams and baseball teams, and even with NBA. So he has operated many famous football players, Olympic medalists. We are going to be able to ask him questions, and we'll be able to know his point of view about current topics and hot news that may be interesting for medicine professionals. And on the other hand, we have Dr. Lena Aslar, that currently has a very vast curriculum. She specialized in sports medicine, not in a traditional way until 1999, but through the current way, through a big amount of master's degree related to sports traumatology and sports management. And currently, she works as medical coordinator of the Real Madrid Academy. Among other specialties, well, she has worked for the Spanish Basketball Federation and so on and so forth. So we'll have a very good point of view of a surgeon and another doctor that has the continuity of the orthopedic um, doctor and the person that would connect the athlete with the physiotherapist or the rehabilitator. And there's some kind of bond between the coach, the physiotherapist, and even the nutritionist, because everything's important in the end. So, that approach, that 360 approach, is the approach that we want to convey from the European University of Madrid and postgraduate school of Real Madrid to our new master's degree that has a unique curriculum in the national arena because it touches everything that I consider that sports doctors should know, starting by module number one focused on the musculoskeletal system from anatomy, biomechanics, traumatological classic injuries, the use of the ultrasound machine as diagnosis machine, as an evolution machine in order to recover from an injury, from a relapse, invasive ecographic techniques. And we have an express module that integrates the point of view of the sports readaptation from the knowledge of physiology of the energy substrates, the physiology of the hormone system, the role that a coach has to play, that a nutritionist has to play, or even that a psychologist has to play, physiotherapist, etc. And from psychoneuroimmunology, from a clinical point of view, there's something quite trendy. The PNI has been quite famous for a few years, and now it's started to be used in the sports world with tennis players. And football players. And we have a very important module about sports cardiology, spirometry, and this is something well, this is what I know the most, the sports physiology, etc. And we have express modules about physical exercise for special populations, like, for example, sports and children, um, sports for elderly people, sports for women, sports for oncological patients, sports for patients with chronic diseases, heart diseases, lung diseases, and we have another express module of sport in special situations, like, for example, medicine for for example, in this case, for climbers, for mountaineers, what changes, for example, for divers, for scuba divers, for alpinists, for climbers. I think that it will be a very complete master that will include an AI module, another one that will have to do with legislation, and other powerful topics like, for example, pharmacology or doping won't be set aside. So, having said this, we will get started with our conversation that will be more focused on the musculoskeletal side because I have the honor of having two great doctors in this sphere. And if you want to say a few words before you get started, the floor is all yours. Now, thank you very much for the invitation. And in my case, to me, it's a great honor to share this webinar with you all. I'm Dr. Leyes, that is a master for me. I've known him since I was a kid. My parents are doctors too, so I think that we can enjoy of this brief session together. I'm sure that we will. Well, good afternoon, everyone. I'm delighted to be with you all. It's a great pleasure to be with Francisco and Elena. And I hope that what we tell you, well, I hope you find it interesting and useful. Okay, guys, so having said this, let's break the ice. Let's start with the first point that will be the role of the doctor of a team, in this case focused on football. What role does it play? How important is a doctor for a team? Because maybe there are people that would say, well, maybe if they have their traumatologist that operates them, they have their physiotherapist that readapts everything, or their coach. Elena, in this case, let's get started with you. You are the person that is linked between the hospital and this football team. So, how important and well, yeah, how important is the doctor? Well, basically, we're trying to take care of our players together with the technical team because we spend many hours together, we travel, we play all together. So basically, it's about accompanying the injured athletes when they get that injured. But I always like to highlight that prevention is paramount, and we have to work at multidisciplinary level with our physiotherapists, our nutritionists, our sports psychologists, podologists. We have a very huge team of professionals, and we work all together. Now we're starting with the preseason, and we are making all the medical and biomechanic evaluations and so on in order to be able to know what weaknesses we will have to face to work on that during the season. So besides that prevention, we have to see the injuries that could happen during, playing when they're playing sport, and to make a follow up since until they are able to play again. So we go hand in hand with the surgeons and with players, of course, and we are working together with the traumatologist team, like Dr. Legis, for example. Yep. In our case, it is paramount. The fact of being, the fact of, well, to work together with the team doctors because of many reasons. The first reason would be because they are the ones that know best what every player needs. They know the timing, they know when it's the best time to start with the treatment, and they know the players very well. So there are details about the player that the surgeon doesn't know that play a key role in the result of our surgeries and our treatments. So with Real Madrid, I have been working with Helena for a few years, and we've been able to solve situations that were quite difficult to solve. And that model is a model that in other countries has been set up for many years. I have been able to work in the US, and they work that way. And in the case of Real Madrid, the doctors that, that play or that work for national teams, And that gives you a great advantage because as surgeons, we really don't know the specific needs of every sport or the best moments to tackle everything. Sometimes we have to stop some players, sometimes we have to put pressure on others. And someone that spends time with them, like Elena, well, it's luxury. Not only that, it affects significantly to the result of the surgeries. So sometimes, Helena, you say, well, with this player, careful because I don't know, he's not scared. He will go for it. We have to stop him. Or with this other player, just the opposite. If we do not convey that feeling of calmness, he will be very afraid. So every single detail and know-how sometimes are unknown by the surgeons. So that close and direct relationship is paramount. And who benefits from that is the player. That's absolutely clear for me. J- One question for Elena. How easy or difficult would be to work in interdisciplinary with a top level player? Because sometimes I have the feeling that having every tool available, maybe his character is not, well, it could be a little bit negative or could jeopardize his recovery because they're reluctant to follow what you tell them. There's a psychologist that could support you, a nutritionist. How easy it is, or if you feel that something has changed, maybe you have not been able to live it because you're younger than me and you're very young. Uh, but I think that traditionally that multidisciplinary approach in the US has been done much before, but in the world of football, it arrived quite well. It didn't arrive many years ago, so maybe the reality is that it's not done the way we want, or according to the point of view of the players. Maybe it's easy to make them perceive that multidisciplinary approach. Yeah, well, I think that it has changed with years and it is increasingly professionalized, even from the foundation. We're not just speaking about top performers, in this case, Real Madrid, but since the academy, since they are playing for the academy, they grew up with a physiotherapist, with a doctor, and we're normalizing sports psychology or even nutrition not only about supplementation, but also to train them how to eat well. So when they grow up with these scaffolding, I would say, and with every tool that they have available for them, that's amazing and that's very important. Of course, you won't force them to follow every instruction, but we train them and we try to educate them since they are kids. And many of them tell me now that well, we are in during the preseason and some players that are playing for other teams are coming back. They say, "Well, it's very cold outside, doctor," and they say, "Well, you have a doctor available for you 24/7, and you have physiotherapists too that are there when you need them." And they are available for them. And if they're not here, they miss that. And I think that our coach, for example, Alvaro Arbeloa, tells them many times, hey, for example, this morning we had a talk and they say, you don't know what you have here. So please take into account everything you have available for you. Right now, it depends on you to take care of yourselves and to work constantly and throughout the whole season. Because in the end, we see this previous work and we see this throughout the season. So sometimes these group of tests, for example, prevention tests, in order to, well, prevent these injuries, they don't understand them until they get an injury. And when they have a long-term injury, we share them with Dr. Layers, like, for example, hamstrings or whatever, and they change their mind and they start to take care of themselves. They say, until you didn't have an injury, you don't start to take care of yourself. I have every kind of profile, I would say. So, what percentage do you think that we have in terms of acceptance? More than 50%, maybe. Well, I would say that. I would say that quite, yeah, much more. I would say maybe the doctor sees comes from different federations and different disciplines, but in, for example, women's football, I've seen an amazing change in terms of specialization, in terms of nutrition, body composition, etc. So maybe we could see well, we could see what he thinks. Yeah, I agree with Elena. Maybe in the private environment, the elite player works with a multidisciplinary team. There's someone that manages their money, their image, their health, a physiotherapist, etc. They basically are used to doing all this from a multidisciplinary point of view. And something else that I would like to mention is that dealing with these athletes will have an important advantage because they have a motivation that the regular patient doesn't have. They have genetic that has helped them or that has brought them where they are. Now, for the ones that have the opportunity of treating them, well, these are advantages. So the ideal patients, right, with a with an environment, yeah, well, because of the demand they have surrounding them. Not everything is beautiful, of course, but I think that coordination and communication are important. When they ask me, well, it's very beautiful on the paper, multidisciplinary team. Well, that's very beautiful, but that communication is important because you have the vision that you have from the club. But as the doctor says, the environment is important because the representatives have their own nutritionist or physiotherapist or even the consultant doctors. So who needs to really make it is the athlete. If they receive different messages, the one who will be affected, negatively affected, will be the athlete. So that's why communication is so important. Yeah, the role of a doctor um, to homogenize everything is important, right, Jose Manuel? I don't know what you think about this. Do you think that it is a key role, and how important is for athletes to recover from an injury? How important is that environment to work at the same level for them to recover? You're a surgeon, but everything that has to do with metabolism, biomechanical, muscles, the habits, etc., all those things have an impact on the recovery, right? Or maybe you can change things when they are injured. Well, I would say that coordination is key. And we need to send a clear message. Let me put an example. A way, well, this the way we work. When we operate a player, we ask him to create a chat with the people that he considers that have to be on this chat. Maybe the surgeon, the physiotherapist, or the representative, the agent in this case. And every piece of information moves through this channel. And that would avoid misunderstandings. It's like I thought, no, everything goes to the same channel, and the evolution of the exercise and physiotherapy goes through this channel. So that makes them feel relaxed because they receive inputs from different professionals that are different. That could create many doubts and uncertainties. For example, with big clubs, with Real Madrid, we don't have to create that chat because we have a much closer communication. But for example, when you operate a player that is not or comes from another city or doesn't have these possibilities, it is very important that coordination and communication are well done. Because otherwise, well, misunderstandings could appear, and these would affect the result of the treatment. Okay, so with these, let's move to the second point that would be about the most frequent injuries in women's and men's football. What differences do we have in terms of the most frequent injuries? Sorry, why do we see them? What ways do we have to assess risk and to prevent these risks? And if there's any change in terms of surgery based on sex? Yeah, I could say that what we find the most on a daily basis, as we speak about football, would be, for example, the lower body, with the exception of goalkeepers in lower categories. They say, do they have injuries when they are so small? Yes, of course. And basically we have, for example, different sprains, for example, sprained ankles, sprained knees, and in the case of muscle, in the case of men, we see more hamstrings, and we see more sequestrators, for example, and for example, the problem that our athletes have would be the long-term injuries, like for example, the cruciate ligament, and this is what would something that we see among women too. And what I was saying about the higher body, sometimes they don't know how they have to fall, and they fall with the extended arm. And we are having, for example, in the case of goalkeepers, we have, for example, shoulder dislocation. But well, maybe the doctor could elaborate a little bit on this. Yeah, the injury pattern, the injury mechanism among women is a little bit different compared to men. In general terms, the injury index is a little bit higher among men, with the exception of injuries like, for example, cruciate ligament that is 3 times more frequent among women. The muscle injuries, especially everything that has to do with hamstrings, are more frequent among men. For example, the fatigue injuries are more frequent among women. And well, as we will see, when they come back after these injuries is different too. The recovery time is different between men and women. But well, it's the same sport, but there are differences. So they don't have the same injury pattern. Why? Well, I think that anatomy plays a key role. In this case, it's a lower body sport. The strength is different, the power is different. And we usually find uh, narrower space for the cruciate ligament in the case of women. The intensity of game is different. So I would say that injuries can't be homogenized in football, and the injury mechanism is not the same either. The most eye-striking thing would be the cruciate ligament. So for the same position, women have this injury 3 or 4 times more. And professionally speaking, it's the same story. We need to take that into account. Even the time to go back to competition, uh, women need more time to recover after a surgery of the anterior cruciate ligament. Maybe on average, they would need 1.5 or 2 months more than men in going back to play. The surgical technique is different too. We use different techniques for men and for women. Yeah, I have a question to connect this for Elena. So, what differences, Elena, may we see for prevention? What's the difference in that biomechanical study with that imbalance of muscle imbalance? I mean, that classical uh, hamstring and quadriceps rating, hormone cycle is. Do you take that into account when prescribing the power loads, explosivity? Because there's a peak there. There's a week when we have more hyperlaxitude, we have more tension on ligaments. What we do you usually do on a daily basis if you do? Well, that's a discussion that we usually have, as the doctor was saying. So, anatomically speaking, women have wider hips and the Q angle is a little bit shorter. We have more laxity. And it's true. Well, everything that has to do with hormones, at, for example, menstruation cycle, we make a follow up with abs. We have different menstruation periods. There are researches, like, for example, Blanca Romero, the physical coach that we have with the Spanish national team. She's relentless in this aspect, as well as Esther Morencos. We need to see how to individualize the different stages. It's true that in team sport it's a little bit more difficult compared to an individual sport, because everything that has to do with dosifying these loads during the training session at a provincial level. A few years ago, that was part of my PhD. We made a research about a neuromuscular coach, a warm up before the training session. We applied that for 12 weeks with a battery of tests about power, about jump, before and after applying that neuromuscular activation training. And according to that, according to has been described in a more specific way with more variables in this among women, we can see an improvement in prevention of this injury. But we know that an injury like anterior cruciate ligament, that is multifactor because of biomechanical factors, neuromuscular factors, motor control, and sometimes women um, need more strength, for example, hamstrings or gluteus, playing surface. Well, you name it, many factors. We try to focus on this path that you were speaking about a minute ago. Yep, and at surgical level, I think that, well, I think it's very interesting. What's the difference between men and women in terms of surgical technique? Well, in the case of men, the election technique in general terms, well, maybe it can be modified for some persons, but we use the central third of Rutolian tendon as a graft. It, in this case, it has a bone on both sides, so the graft is very short. And sometimes we have an extra articular reinforcement, and this would be the long gold standard technique for men. In the case of women, sometimes we find that the width of the Rutolian tendon is not enough in order to have a thick graft for the future ligament, and we could weaken the extension system if we do that. So sometimes we don't have the minimum thick in terms of well, for this tendon for 30 millimeters. So we have a bigger trend to use quadricipital tendon that is one that is thicker than the patellar tendon, and we can have enough size for a woman. Women have a high risk to relapse So we have an extra articular reinforcement in order to control rotation. In the case of men, it's quite frequent, but not always. I would say that in case of women, 100% of women football players that we operate, we use that extra articular reinforcement. This is for football, but technique would change for other sports. I always said that the cruciate replacement is a tailor-made suit. So you can't take the hamstrings of a speedrunner, for example. You shouldn't take the patellar tendon at a sport where you have to be on your knees, for example, basketball. Well, not that much, because in basketball there was a survey in 2014 among doctors that were in charge of the NBA doctors, and the question was very simple. They asked them, what ligament would you choose for a player of your NBA team? And more than 80% said patellar tendon. Although it's a sport where you have to jump, what we've seen with patellar tendon is that the most frequent complication would be some pain at the anterior face of the knee, but it can be better managed at sports level. I see more pain in the anterior face of the knee among amateur players that don't control loads that much compared to professional athletes. Of course, we see that. Elena and myself have a couple of them that are being a little bit problematic, but it's easier to manage them at professional level rather than at amateur level. So, what strategies would I have to follow in order to mitigate that femoropatellar pain with an HPH technique? Would it be an indication of PRP, hyaluronic acid? Is there any protocol for cases? Well, I've seen some players with these symptomatology. What do you use on a daily basis according to protocols? So the pain that is, well, the one that is the most difficult one would be the one that is at the lower part of the rotula in this case. So the first and foremost would be to try to prevent that, to be very careful with load management. So they need to recover the volume of quadriceps, and they shouldn't try to make the patellar tendon annoyed, if you understand what I mean. So the problem is when they're recovering, because the quadriceps is not assuming the loads and the tendon is complaining. If it has already been established, you can try PRP. We have some cases that have worked. We've also tried to use CPI. And I remember a case, a player of Betis. In the end, had to go under surgery. It's the only player that I remember, professional player. It was impossible to solve it, and we had to operate him. We have to remove the harmed part of the tendon and to make a reinforcement. But that's exceptional, I would say. Where did you take the graft from? In this case, the surgery was in Seville. He was playing for Betis, and we did the initial surgery. We tried everything, it didn't work. And I think the reinforcement, maybe I'm wrong because I was not in charge of the surgery, but it was by Paco Montilla, and I think that he used a donor. He used a donor not to remove any hamstring or to touch the knee of the patient, but I don't know that 100%, but that's what I think. How important, Elena, is the HQ strength ratio? Do you measure that during the season? Do you monitor them? Do you make a follow-up of that imbalance? Do you do that at the academy? Do you do all these things, or just in case of where there are injuries, and then you start considering different aspects? Well, in general terms, as I was telling you at the beginning of the webinar, at the beginning of the season, besides of cardiology, anthropometrics, we have a part that we develop with our physiotherapists and physical coaches in terms of mobility, dynamometry. strength. So we see the initial stages where we're in. If there's an injured player, we adapt it, of course. So this way we can have a basal situation. Uh, so if we have an injury, we are able to make that comparison. And do you think that currently there are no differences in terms of resources between women, professional women, and men? Do you think that generally speaking, there's an imbalance in terms of resources to prevent and to recover from injuries? Do you think that there's a difference between men and women? So I think that currently, where everything is evolving, as we used to say, in terms of resources. Some years ago, I used to collaborate with the Spanish Federation and the Madrid Federation, and in a few years, we've seen an important increase, an important improvement in terms of structure. Even in this case, I worked for Patacon, that is a current women Real Madrid, and they have three teams at the academy, and they're growing in this sense. They have physiotherapists and they have adaptators. So I think resources are improving as well as happens with national teams. Since I started in 2017, well, in 2017 they didn't have a doctor in the Madrid team at regional level. I mean, and it was the first time when they had a doctor, and I can't say. I mean, I've lived that in first hand. I've worked with players in these categories, and they really want to give women the same as men have. So we find in amateur football and at federation level, we sometimes find that, of course, there are teams that are growing. But I think that, well, step by step, and the number of players have skyrocketed in these last years. And I think that that's very important in terms of motor control, for example, as we were saying. I think that, for example, when we performed this research, we didn't have that physical preparation. They had a first and second coach. Now they all have different members of technical staff. We see that just with a very little things done in terms of being able to know how to jump, how to land, to know how to run. We all see that improvement in the prevention of all this. So I see, and Elena, please correct me if I'm wrong, and there's a huge difference between football and other sports. Yeah, that's true too. We focus very much on football and we forget about the other sports. Yeah, totally right. Football plays at a different level, I would say. Yeah, well, when we have other kind of patients from other federations, well, that's not the same. Since 2021, after COVID, we were starting to extrapolate different protocols to the Spanish Federation of Basketball and CSD, and I continued with with all these tasks. And it's true that at the Spanish Federation, we have the means in our national teams, but of course, we still find that we have players that can't afford some treatments for their clubs or some follow-ups that we make from the federation. So according to Dr. Leyes, we see that we have room for improvement. So in the case of a clinic and consultation, they really use us a lot. And what about kids? So what about kids? Would it be like women? Maybe that's a special case in terms of physiopathology, prevention. Maybe what we are seeing right now, or the sequence that we see in terms of deficiencies, could be dragged from professional men to professional women and the academy, right? I think that that prevention among kids is more important than that load dosing. I think that that's risk factor among young athletes that is not taken into account. And generally speaking, when we are aware of it, it's late. Because, for example, a 16-year-old player that had a great projection, that had a great future, well, maybe he can't play anymore. So, what are the positive factors in order to prevent these injuries from happening in Spain? And what's the difference compared to other customers that could be taken into account in terms of biological maturity range? Well, it's called biobanding in the US, I think. The categorization of the athlete according to the biological maturation and not chronological. Do we have room for improvement? What are we not doing well? What can be done differently? Well, in our case, I think that we always try to tell kids that they can practice different sports and different physical activities and to develop it and to choose what they like. But it's true that we fall in specializations, I would say. And at football level, sometimes when we hold the meetings, we'd say, why do they injury? Why do they injure? Sorry. So, so the more exposure, the higher risk to be injured. So we need to take into account that maybe we used to train Tuesdays and Thursdays, and you had a game on the weekend, and now you train minimum 3 days plus the game on the weekend. So, since they're kids, we work with physical coaches in terms of that psychomotor procedure because they have different maturation, the motor control, etc. And it's true that maturation is taken into account, but it's difficult to have teams just based on the maturation range. And this is something that we can say throughout the year because, for example, when we have children between 10 and 13 years old, there are players that during the year, for example, they grow a lot, they're much taller during the summer, and we control that. And I always like to say that children are not small adults, they have their own injuries. And we see that in our practice. We have epophysitis, SIVA. A few years ago, a coach asked me, what's your recommendation of the first day? They shouldn't be shooting to the goal constantly because they come back after the summer. Yes, they have injuries at the lower limbs, so we see that that's a weakness sometimes. And what could happen is that they can have an injury if they do not deal with that correctly. And that would be the idea. That is what we see on a daily basis. Many types of these pathologies, I would say. Okay, and what are the surgical differences, Manuel? Well, in the case of children, we need to take into account that we shouldn't hurt physis, not in order not to affect the growth of the limb. That's a fear that families have. And I would say that it would be much more difficult not to go into surgery because children as opposed to adults. Well, it's very difficult to stop them, right? Yeah, totally. It's like, well, let's wait for him to grow a little bit more and we'll operate him. That would mean a disaster because they don't listen to you and they have injuries that are difficultly resolved. So, for example, they could have injuries at the meniscus or different areas. For example, of the cartilages. But if there's a cruciate breaking, you have to operate them. And we use different techniques, be extrafissurary techniques, for example. We can rebuild a crushed ligament without the need of going through the growth cartilage. It's true that it's a smaller cruciate. It will have to grow with the kid, and there's a possibility that when they are adults, they can break it again, and we have to review the procedure. But that has a solution. What doesn't would be, for example, a cartilage injury, a meniscus injury, and this is why we operate them all. I would say that there's an epidemic right now, and in our practice, we see um, more children with this kind of injury. And what Elena has said, the fact that children are specialized at a very early age in every sport, I think that this makes them more vulnerable to be injured because they do not develop skills that they would have developed if they had played different sports. For example, the well, workloads and such small kids are not controlled, and children have growth peaks. They move in a less coordinated way. They don't have muscle development as adults, and not about when they come back after surgery. There's consensus in the sense that a cruciate in a player that is younger than 20 years old, well, they need 1 year to go back. If they're younger than 20 years old and they have broken their cruciate ligament, they need 1 year to play back. And that's another reality that I know that we don't like it, and it's difficult to say this, but it is very, very difficult that a kid that has been operated with open physis is able to reach elite. It's very difficult, not only because of the result of the surgery, but also because they have gone through this at a very early age. So they start to see all these situations, and there are just a few cases of players that have been operated at a very early age that are able to reach elite. So, do you take into account the puberal growth peak? Sometimes that I've given talks about this. I think that this is something that we've broken, right? That early specialization. I think that there are studies that take into account that it's even easier to reach to the elite for those kids that have played different sports, right? Because in the end, this is what you've said. There are motor skills that are acquired from other sports that could complement that sport very well when they succeed. There's a lower rate of burnout for that sport. There's some kind of way out in terms of pressure, right? It's like a relief valve. So I'll have to be the best in football, but I play tennis with my father. I have a good time, and that is accompanying me. But another important thing would be what Elena was saying, right? Before that pubertal growth, before that testosterone peak, these are very small muscles with a high demand at tendons level. There are longer bones and tendons and ligaments have that situation. We don't have these muscles that could preserve them. So how do we recover? I mean, there are no surgical differences. Well, I guess so, because if the cartilage is closed after the pubertal growth peak, there's a different techniques. And where we will see the most important difference will be in recovery. I would like to connect this with return to play with a cruciate ligament. How do we take that into account among kids? Do we have this 1 year rule so that we are not in a hurry and that's it? So the year is just to set a date according to which we don't have the pressure either from the kid or from his parents. It's true that return to play does not depend on chronological factors. Right now, we make many measurements that tell us when it is safer for this kid to play again, to return to play, basically. But we don't have that pressure. Well, the kid is great and he wants to play now. It's true that it's more difficult for them to recover the muscle tone compared to the more mature players and with the more with that tone. So that management would be different from after the surgery. So control, pain control, post-op control, that fear control, the fear when you operate a kid and you tell them that they have to bend his knee, that's this much more difficult. And if you don't pay attention, we will have more problems among children because they will be more afraid to go back to play. They've gone through a serious injury. It's difficult for them to lose that fear. We have to adapt the protocol to the patient's age, sorry, and we have to be realistic. If you feel that the kid has a great career and that the future will be professional football, okay, but I've had kids in their 13, 14, 15 years old with both cruciate ligaments broken. So my obligation as a doctor, besides of operating them, is to tell the family, hey, I think that health comes first, and you should make your kid play sports with less risk. Although it's a very tough decision at that age, because well, the future of those knees will be important. I'm not speaking about top players. If someone will play football and it's going to be his life or her life, okay, let's go for it. But sometimes we see amateur players in our practice with very difficult knees at a very early age, and we have to convince them that there are sports that are less dangerous for them. So, what risks do we have with that person that would decide to return to play after 3 or 4 cruciate operations, or for that person that doesn't want to operate that cruciate ligament, they prefer to play their sport with a broken cruciate with the instability that that would entail? So, if you make a private sport with a cruciate, well, there are some weird exceptional cases that we call copers that are able to do it. They have no failures, but the normal thing would be that the knee fails, and every fails is lottery. For example, if you fail, you can have a chondral injury, and the more fails you have, the worse. Or the more dangerous it will be for your knee. Many people end up with knee prosthesis at a very early age. It's not infrequent. We've seen many prostheses at many former professional players. Yeah, I think that it's true that speaking about elite sport is not the same when the athlete that is at the elite has an injury compared to the one that is close to that elite. It's like natural selection, I would say, in this case of these pathologies. Yeah, when we operate a player, we tell him or her that 90, almost 95% of the players go back to go back to play, but more or less 65% go back to the previous competitive level. So going back to play the same minutes, to score the same goals, to have the same speed, to be an important player, that's the pending issue. This is what we have to do. We have to make every player to go back to the same competitive level. And surgical technique plays a key role, but the position of the player is important too. It's not the same to operate a forward that is very good because he dribbles, he's very good, he scores many goals. It's very difficult for this player to go back to competition. That's not the same as if you operate a more defensive player. And you see the paradox that defenders have more injuries because they are not having the initiative when they're playing, but it is more difficult to recover the forwards when they are, well, when they have an injury. What 3 evolution milestones do you use in your practice in order to unblock stages? And we get into the RTP, the return to play stage of a cruciate. We're focused on the cruciate. I think that that's one of the most important things of football. So you have to split it into stages. To make the long story short, what milestones in the progression would you set? Knee bending, load, power, etc. Well, when we get to the operating room, we try to control pain. Sometimes players go to their houses and we are in constant touch with them. Everything that has to do with temperature, if they have fever or not, what degree should be reached. We control that, right, doctor? In terms of analgesia, for example, they start working with us, and we just work with quadriceps until we remove, in this case, the stitches, and we do everything hand in hand with our physiotherapists since the very beginning, since they join us. Before they join us, they're working with them. And luckily, we have that amazing communication with Dr. Leyes in order to overcome that stage, that initial strength and the mobility stage. Well, these first 6 weeks are very important. And when we start with the next stage, it's important to, as the doctor will say right now. Yeah, well, to make the long story short, until they start with bike and water, etc. Yeah, well, the first stage, as Selena has said, is to control pain, to recover mobility, and a normal pattern. Unless there are associated surgeries, for example, a meniscus breaking or root breaking, the normal thing is a young guy. So after 1 month, they could walk well without crutches and with a good mobility range. When I'm saying good, I don't mean complete. We're not interested in having the full flexion very quickly because when you do an hyperflexion, the plasty is not included. It's not incorporated yet. And that could create a slide of the graft and you lose stability. So there's a key moment that would be the 6th week. So the bone pill would be included in the tunnels. So the stability you have in week 6, the passive stability, where you explore, in this case, with the different maneuvers that you develop at the stretcher, that would be paramount. You have to do that, and stability laxity would be important. You'll have them after 6 weeks. The graft has already been consolidated, so you can work with power in a much better way. We have a very long stage, subsequent stage, that would be about balancing the muscle mass until 12 weeks, more or less, I would say. Yeah, that's it. That's a very long stage. And then we should start we should make them run a little bit. And the final stage, that would be the most difficult one. That is, when are they coming back? That's the most difficult part of all. Because we usually use 3 types of parameters. We measure the strength that are not objective. We use image parameters when we measure the maturation of the graft, and it's a parameter that is not very useful because it's highly variable. You can find a player that has been 14 months under surgery, and in the MRI you see that everything's not totally natural, but there are others that mature much that get well sooner. So the most important parameter would be the player and the people that surround him. that are the feelings that he has on the pitch. Yeah, sorry, sir. Yeah, go ahead. It's true that, to make the long story short, for the students to know this, we move from this part of medical physiotherapist and the gym with the physiotherapist, etc. And we focus on the knee, but with the other muscle groups and even cardio sport. Because there was someone that was asking me, you do cardio in many different ways. Because with hydrotherapy, well, you're doing cardio and you're doing that with the bike. Even at the beginning, for the upper limbs, you are doing cardio too. So it's about accommodating all these stages to the process. And as the doctor was saying, we have that first stage with the readapter on the pitch, even to incentivize these skills with the ball, even at positional level, so that they can see that they are back to the competition. But the one that, well, the most difficult one, and the one that we are always negotiating with the players, is that, well, sometimes the environment, and as we were saying before, or the coach, well, we always try to convey that message of the 10 months or even 12 months when they are younger than 20 years old because of maturation, but that the end of the tunnel would be to accomplish short-term goals. And we would have to agree with the physiotherapists and the surgeons in terms of the green light. So green light to start running, green light to take steps and to set goals, because it's true that at the beginning it's a difficult moment, and this is what they like to do. And at professional level, if you are going through a good professional time, well, this has happened to players sometimes. So it's important to accompany them all. And the patience is paramount and how to manage this people. So we need to have joker tasks, for example, with the team. We have to develop the first two tasks with the readapter so that they can offset the others. It's like, well, I've been training with the readapter more than with the team. It's like, hey, step after step. So little by little. In 2 weeks' time, maybe we can develop different tasks. So we will be dosing all this. And right now that I have different players at this situation, they are starting to think, when am I going to compete? So in that case, besides of all this, we do the MRI in order to see that plastic inclusion. We perform different maximum strength tests, jumping tests, asymmetry. Sometimes we see that with Lexa. Sometimes that we've started this with Castilla, with the second team of Real Madrid. We see anthropometry and we see the muscles of both legs. So with all this, we're able to make the decision that, well, maybe they can start with 10 or 15 minutes and we progress week after week. And what I see during these last years is that the coach has the image of the player at the very beginning, and they think that they're going to go back the same way. But until they have not been training for 1 year and a half, that preseason, I would say, when the other teammates are already competing, well, maybe starting with that dynamic is going to be difficult, and they see themselves that they are not at the same level as they used to be. So it's a matter of time, but they have to be patient, although it is difficult. Okay, guys, so it's great to listen to you all. We could spend hours here, but I'm afraid that we have to finish this webinar. It has been a great pleasure and a great honor to listen to you all, and I would love to speak to you for hours. So, for all the students that want to deep dive in all this, we see that sports doctor is a very complex entity that extrapolates much more than usual orthopedics, or usual readaptation, usual nutrition. I think that it's a very important figure, as we've been able to see as a global doctor, as a family doctor in a team with special needs, that there are clear differences in terms of well, both sexes and age groups. I think that it's important to keep in mind that prevention is key. It's a paradigm shift, and everything that is invested in prevention will have a positive impact on recovery. And doctors, as Dr. Layers, can see that very clearly, how the response to injuries have changed. And part of this, well, an important part of this has to do with all this stuff. And a multidisciplinary team where we have the physiotherapist, the sports doctor with the MRI teams, well, that's paramount. And injuries like cruciate ligament are very frequent. And there's a physiopathology that is very complex, that integrates many sport disciplines that we can be thinking of, and they're all interesting, as from biomechanics to anatomy or training sessions. And I would like to say thank you to both speakers for the quality of their explanations, and I hope that I see you very soon. Thank you very much, Francisco. Thank you. Thank you. It has been a great pleasure. Thank you. Cheers.